So I was asked to talk about the expansion of immunotherapies, specifically bispecifics and trispecifics, when and for whom, proper grammar, I like that, for whom, combination sequencing, and expert care examples. Okay, I think this is really an important slide, and it just shows the response rate and how long the remissions last for recently approved drugs. So the 4 drugs on the left, many of you know, pomalidomide, carfilzomib, dara, selinexor, they all work in about a third of patients, so 30%, but the responses only lasted 4 months. And now, in the breakout session, I was saying, when I left New York, many of my patients had exhausted all those drugs. We had talked about hospice, and then they entered these clinical trials with the drugs on the right, and they became in stringent complete remission. And keep in mind that the drugs on the right, not only are they active, they're active in people who've exhausted all those drugs on the left. So you're taking sicker patients and getting better responses. And so the responses for these T-cell redirections are anywhere from 60 to 100% essentially, and remissions lasting in the light blue 1 to 3 years. So I'll be focusing on the 3 bispecifics that we currently have, Talquetamab, Talquetamab, and elranatamab. They have a very similar indication, so these are for 4 or more lines of therapy and have exposure to IMiD, PI, and CD38. And so why do we need bispecifics? CAR-Ts are great, and no one can discount the importance of CAR-Ts, but I want to just call your attention to the CARTITUDE-4 study, which I'm sure Dr. Costello showed. I wasn't here because I was on a flight down here, but CARTITUDE-4 basically compared cilta-cel or Carvykti to standard of care. And on the left, you can see on this graph that the red curve, which is cilta-cel, sits higher than the black curve, which is the regular chemo. So higher is better. So this means that the myeloma remissions were longer with the Carvykti. And then in terms of how long people lived, also better with Carvykti, right? So both remission durations and living longer better with the Carvykti cilta-cel. But what I want to call your attention to is the beginning of these curves. These curves will cross over, meaning the benefit of CAR-T is not immediate. You have to actually get to the CAR-T and stay alive long enough to see those benefits. And this is where bispecifics have a role. And so what I mean by that is, yes, CAR-Ts are amazing, and we have more expansion in terms of approval and availability, but the 2 major barriers to CAR-T are, number 1, what we call brain-to-vein time. The time that a patient, we have to know that the majority of patients in the US are being treated in the community, not in academia, probably 80%. And so when those patients are being treated in the community, and the community doctor is like, you know what, you may be a CAR-T candidate, they have to refer to the doctor at the center that does CAR-T, the consult has to happen, insurance approval, the T-cells have to be collected and then given. And that time is what we call brain-to-vein time. It's not vein-to-vein. People talk about vein-to-vein, which is when the T-cells are collected to administer, but I would add to that brain-to-vein time. And the problem is that if you have rapidly progressing myeloma, you don't have that time. And then the second problem with CAR-T is that once you give those T-cells that are genetically modified, you can't do anything about it. The expansion happens. And so if you have a lot of other non-myeloma medical problems like heart failure and other things, it's hard to get through CAR-T. And this is where bispecifics shine. Instead of this long brain-to-vein time, they're off the shelf. They're ready to go. The drug is available, and it's the same for everybody. And if there's side effects, you just hold the drug. And so I alluded to this as well, but if you think about who's eligible for what, transplant is probably the smallest. More patients can get CAR-T than transplant, but I would argue pretty much everybody can get a bispecific because there is no absolute contraindication. So I've always said any patient with myeloma who wants more therapy and meets the current eligibility, as I mentioned, the 4 lines of therapy, or in a clinical trial should be offered a bispecific. And the other thing is this eligibility also correlates with access. In the interest of time, I didn't show this slide, but I have a slide where CAR-T is like a Rolls-Royce Phantom. You all want it, but very few of us can get it. And the bispecifics are like the Toyota Corolla. And you know what makes the world go around? It's the Corollas, not the Rolls-Royces. And so if in the US, this is a shocking statistic, if only 12% of US patients who are eligible get a transplant, and CAR-T is even more restricted because of the centers that are approved, whereas bispecifics can be given at any cancer center, as long as they do their training, which is limited, but you don't need to go through this lengthy accreditation process. So I think bispecifics will, if you have to ask what drug will change the outcome of patients in the world, it'll be a bispecific. So before we dive a little bit deeper into bispecific, we should say, what is a monospecific, right? What's a monoclonal antibody? And I think this is a fun fact. All monoclonal antibodies, which are basically laboratory-produced proteins, they mimic the antibodies that we all have, and these antibodies are designed to bind to targets, which we call antigens. Every monoclonal antibody that's approved in human beings, whether it's for autoimmune conditions, cancer, owes its legacy to myeloma, because in 1984, these three folks listed there took a spleen cell from a mouse and myeloma cells from a patient, fused them together, and those hybrid cells became antibody factories. So basically, they changed the types of antibodies that these would produce, and that's how we got every monoclonal antibody, whether it's Rituxan for COVID, for autoimmune. But the first myeloma antibody didn't come for almost 30 years. In 2015, we got daratumumab and elotuzumab. How are those different than bispecifics? You can see in the Y-shaped structure at the bottom, both parts of the Y which bind the target are the same. They bind the same myeloma target. Bispecifics have that myeloma target on one arm, but the other arm now binds what's called T cell antigen, right? So a protein that's expressed on T cell. So when you do this, this is kind of like a double-sided tape. What it does is brings your T cells right up against the myeloma. And if we think about myeloma as a failure of the immune system, you either need to artificially stimulate the immune system by CAR T, or within each patient by using the double-sided tape. When the T cells are brought near the myeloma, they actually recognize the cancer. They release the chemicals as shown in the cartoon on the right, and those chemicals or cytokines poke holes in the myeloma membrane and the myeloma cells die. These bispecifics, as I mentioned, are off the shelf, ready to go when you need it, and everybody gets the same antibody. It's not like CAR T where you need to manufacture it. This just shows how quickly this type of modality is changing cancer. Since 2014, you can see there's now, I think, 10 antibodies and for all these various different conditions. And we have 3 for myeloma that I showed you on the first slide, Talquetamab, Talquetamab, and elranatamab, approved in October 22 and August 23. But the point of this slide is bispecifics are the new monoclonal antibodies. They're here to stay. And where we were about 20, 30 years ago with monoclonals is where we're going to be in the future with bispecifics. Everybody's going to be getting a bispecific at the cancer center near you, regardless of the cancer. And the reason this is important is myeloma is a little bit on the cutting edge, but generally what the most common cancers in the US are prostate, lung, colon, and breast. So those cancers, if they get a bispecific, community doctors are going to be very quickly on board, right? Because myeloma is relatively rare. But once you get the common solid tumors, everybody's going to be very familiar with this. So I think it's just a matter of time. We're in a pretty steep learning curve, but it's an exciting time. So how do you pick the target for a bispecific? Well, the ideal target should be one that's on the myeloma cell to obviously kill the myeloma, but also not elsewhere expressed, because that's where you get the side effects. So how do you pick that target? This is a busy slide, and I'm not going to go through all of this, but basically you could pick any of those things on the bottom, all of those different bubbles at the bottom in various colors are potential targets. And the 3 most advanced for bispecifics are BCMA, GPRC5D, and FcRH5. So these are proteins that are primarily expressed on the myeloma cell, but not in the other parts of the body, and that's why we think that these are ideal targets. But nothing is perfect, so when we look at BCMA or B-cell maturation antigen, yes, it's universally expressed on plasma cells, but also some parts of the immune system. You can see on this slide that when a cell starts in the marrow as a toddler and then becomes mature and graduates college, the BCMA expression is expressed on the teenagers and later, right? Which means that it's not just the myeloma. Some of the other cells also express BCMA, and that leads to some of the side effects like infections. And you might have heard from the BCMA CAR T that there's a part of the brain called the basal ganglia which also express BCMA, and may be the reason we sometimes see Parkinsonism, but more with CAR T. We don't usually see that with the bispecifics. GPRC5D stands for G protein coupled receptor class 5 member D. So this protein on the right is a cartoon. It's anchored in the cell wall, so it's kind of, unlike BCMA, which can actually be floating around in the blood, this doesn't float around, it's just stuck on the surface of the myeloma cell. That's important because then it doesn't act as a sink. So for example, BCMA, because it floats around in the blood, if you're targeting that, some of it could bind on the blood BCMA, not on the myeloma BCMA. This is only on the cell. But GPRC is also a little bit dirty, like BCMA. It's not just on myeloma, and importantly, it's About plasma cells, it's only on cancerous plasma cells. It doesn't seem to be as expressed on normal plasma cell. That may be why we don't see as many infections with this target, but we do see skin and nail changes because that's where this is expressed, some parts of the tongue, and then parts of the brain called cerebellum, although we see more of those side effects, again, with the CAR-Ts than the bispecifics. I think you guys already covered cytokine release syndrome with CAR-T, right? Yeah, so I'm not going to go through this in detail. It's the release of the chemicals and can be fever, low blood pressure, oxygen. But I think the main role of this bispecific, or the main tweaks on this is it doesn't tend to be as severe as CAR-T, right? It's generally mild CRS, and the way we kind of mitigate that, you can see in the management, is step-up doses. So unlike CAR-T, where you give the product in one bag and you're done, bispecifics, you do step-up doses. So you give anywhere from 1 to 3 doses that are small in quantity before you give the full dose. And what that allows the body to do is become accustomed to it. So you give a little bit, and then the body, if you're going to get a fever, you get that. And then you can slowly then go up on the dose, as opposed to giving everything at once and creating a lot more drama. Tocilizumab is being used. That's the anti-IL-6 blocker, because that's the chemical that we think causes CRS. And there's a lot of interest in moving bispecifics to outpatient. So the current label for the bispecifics indicate that when you're doing these step-up doses, that patients should be monitored in the hospital. But should is being interpreted very differently by different institutions. Some are saying that means hospitalization. Others are saying you have to be within the driving distance. Some are saying you come every day to the clinic. So depending on where you're getting treated, it could be any of those things. But the reason I mention that is there's thoughts about, well, if CRS is, let's say, 60 to 70% of myeloma, why not just give prophylactic toci? So why wait for the CRS? Just give it to everybody up front, because it lasts in about a week. And what we now know from the prophylactic toci or preventative toci is the CRS rates goes from 70 to 90% down to 10 to 40%. So halved by the overall rate. However, we're not seeing as much of a drop in the serious CRS. It's primarily grade 1 CRS, which means just fever. Okay, so you've gotten rid of the fever, but those sicker patients were not necessarily making as much a dent. But outpatient dosing is being pursued at many institutions. This other side effect called ICANS, which is immune effector cell-associated neurotoxicity. This is, again, we think the chemicals that are released by the T cells go into the brain and maybe some cells that go with it. Typically, people might be a little bit confused, but again, we really don't see severe ICANS. I can tell you I've probably treated now several hundreds of patients with bispecifics. I've never even called a neurologist because it's a non-issue. This just resolves. Typically, it overlaps so much with CRS when you have a fever. I mean, guess what? If you're waking up a patient at 2 a.m. when they're having a fever and having them do a mini mental status and like going through all these complex neurologic, we're all going to do badly at that time of night. So usually that gets better, and this is a non-issue. There's a lot of talk about dosing of bispecifics, and I want to just mention that the initial dose is important because how do we do clinical trials? We always start with a low dose, and then we see if there's no side effects. We go higher and higher. We push the doses till we think we're getting the best response without causing too many side effects. And why do we need the initial dose? You can see on the left, the blue bars are the 2 approved dosing of bispecifics, and the green are lower doses. And when you don't give adequate bispecific, this is of a drug called Talquetamab, you don't get as much T cell activation. So you need to give adequate dosing. And on the right, you can see that if you don't give adequate dosing, the remissions don't last either. All the patients who had long remissions at the top of this swimmer's lane plot, which is how long the patient stayed well controlled, all the patients at the top got higher doses. So the message here is you need to start with a higher dose so you can get that T cell activation and longer remission duration. However, once you've gotten that dose, now we think maybe you can back off. And not just for safety, but maybe even efficacy, meaning how well it works. And why is that? On the panel on the right, you can see that when you plan to reduce the dose, shown in the blue bar in the middle is less expression of these certain proteins that indicate T cell exhaustion. So like T cell exhaustion, we joke about these teenagers that party too hard. If you keep doing it over and over, they just peter out. And by giving it a little bit less frequently, we think they're better functioning. And that may be why, interestingly, as I mentioned, Talquetamab has 2 different doses, weekly and every 2 week, but the every 2-week dosing actually is a 50% longer remission. And perhaps it's because you're not exhausting the T cells as much. So I think the message here is you start strong, but then maybe you can back off on the dosing. What about not continuing everybody forever, right? Because historically, all myeloma drugs are given until either it stops working or patients can't tolerate it. But because we're getting such profound responses, do we need to give everybody drug forever? Can we stop it? Here's a study with this drug called Talquetamab, which is not yet FDA approved, but it's another bispecific. And they looked at about 250 patients that were in treatment. And then after 1 year of therapy, those who were still responding had the ability to stop. The problem is it was only 7% of patients, so it's not a large data set. But what you can see on the same plot here, a black arrow means that they're still in response. And you can see out of these 18 patients, almost everybody has a black arrow, except those 3 patients or 4 patients in red, which means that about 80% of patients remain in response even when they stop the drug, right? Which is very tantalizing. Maybe we can give people breaks. And could this perhaps also help with sequencing? In the breakout session, we were talking about sequencing. If you stop the drug, maybe these T cells, the teenagers, don't get exhausted, and then you can do other things with them, rather than trying to do, take exhausted T cells and have them get another bispecific or CAR. But we just need more data because this is a small data set. Remember that there's still unmet needs in myeloma, extramedullary disease, high-risk disease, prior redirection therapy. So I'm not saying everybody should go and stop their drug, but it's a risk-benefit decision that needs to be individualized for each patient. But this is kind of tantalizing data. What about side effect management? As I mentioned, the BCMA side effect is primarily infection because it's not just expressed on myeloma, but the rest of the immune cells. And because of that, we're seeing very severe infections and even deaths with this product class. So how do you prevent these infections? Well, preventative medications, everybody should be on shingles prevention. And also, there's a rare opportunistic infection called PJP, pneumocystis, and that requires a pill to prevent, and that's specific for this type of bispecific. We now know that BCMA bispecifics basically paralyze your immune system. So if you want to vaccinate somebody, it's best to do it before you start, because once you start these drugs, the antibodies essentially get zeroed out. So you're not going to respond as well. So if you have the ability to start these vaccines, whether it's flu, RSV, COVID, those are the seasonal ones that you should try to do that before you start. Once the bispecifics are started, it's really important to boost up those antibodies to prevent infections with IVIG monthly. And then because these drugs can sometimes cause low white counts, you want to give shots called GCSF or Neupogen, Zarzio, some of the terms you might know, to help boost the white count. Luckily, those tend to respond very well with these shots. Obviously, if there's an active infection, you want to make sure you're treating the right thing. Is it a bacterial infection, viral infection? Fungal, we don't see as much. And then, so use the right therapy. And then also hold the drug, right? I remember in COVID pandemic 2020 in February, we were in Mount Sinai and we were like the epicenter of COVID. Every day, one floor of the hospital would go from cardiology to COVID, gynecology to COVID. And we had a lot of myeloma patients on these bispecifics. So we stopped the drug because a lot of these patients were in remission and we didn't want them to come into the hospital and get exposed to COVID. And luckily, these patients did very well. And it goes back to that earlier, we weren't sure if we could hold the drug or not, but COVID made us all learn the hard way. And it looked like if you're in remission, you can take a break and not have the myeloma go back up promptly, especially for active infections. What about GPRC5D or Talquetamab or Talvi? How do we manage that? Number one, I would say, is educating the patient and the caregiver about what to expect. These are unusual side effects that people will not have seen before, and so it's important to know about them. And the important thing also is it's one of the few myeloma drugs where the side effects correlate with response. So the 3 main categories of side effects are oral, skin, and nails. And so oral, primarily loss of taste, what we call dysgeusia. Skin, rashes or peeling of the hands and feet, and then nails can get soft and brittle. What's interesting about these side effects is that if you get these side effects early on, there's about a 20% higher likelihood that you're going to get a response. So it's one of these rare drugs where the side effects seem to correlate with the response, and there are other drugs like this in oncology where if you get a rash, it usually means you're responding. I'm not saying it's a one-to-one, but the good news is the drug works in 70% of patients. But these side effects are also quite common, so it's hard to tease it apart. But the point I'm making is that sometimes if you're getting these, it's actually a response. You need to engage, we talked about in the breakout session, interdisciplinary team. This is where you get the nutritionist, nursing, your entire team to help. help care for these patients. So what do we do about oral toxicity? With the taste loss, we really haven't found a good solution. Probably the mainstay is reducing the dose and frequency, especially after that initial disease is controlled. For dry mouth, or called xerostomia, hydration, chewing gums, salivary substitutes, weight loss. This is very important because when you lose weight, you have to adjust all your drugs, blood pressure drugs, diabetes drugs, thyroid drugs. So it's important to adjust those so that people don't have side effects from them, and also maintain, we were talking about in the breakout about the importance of diet, really trying to maintain weight with high caloric supplements. And then of course, if you have complications, treat that. The skin, I would say, is pretty easy to treat in terms of it happens early and it's reversible. So you give moisturizers, topical steroids for a limited rash, and if it's severe, give a short course of oral steroids. This also applies to the hands and feet where you have peeling. And with the nails, you can try nail hardening solutions, vitamin E, and also things to keep the nails hydrated. Okay, so that's kind of our current status, but where do we go in the future? What's the future of these drugs? How do we overcome resistance and improve them? And there's basically kind of 4 buckets of improvement. One is looking at the structure of the bispecific itself, maybe doing trispecific and having more than one target, changing the binding affinity for the T cells, or maybe even targeting a different cell than T cell, like the NK cell, combination therapy, and moving these into less heavily treated patients. So let's look at the new data. So the structure, the 3 bispecifics that we talked about today are all on the left, and they have a very similar structure chemically. And then there's a lot of other drugs in development. So we have the Harpoon in the next row. I don't think I have a cursor, right? Oops, sorry. It's a small molecule. It doesn't have that Y-shaped structure, so it tends to have a shorter time in the body, so you need to make that live longer. Linvo is actually being submitted to the FDA. It's another BCMA bispecific. ABV383 is another one. This one is unique because it's actually purposely designed to not bind the T cells as actively. And so it seems to have lower rates of cytokine release and less need for step-up dosing. So that's something that might be better for outpatient dosing, so stay tuned. There were 2 products that were trying to bind the tumor with not just one site, but 2 sites. So you can see it had 2 orange myeloma binding site, but unfortunately both of them have been withdrawn from development. Alnuctamab and Furentemig, they didn't seem to have a really different clinical profile, so those are not moving forward. There's a tetravalent with 4 binding sites that's presented, and the one that's a lot of us are excited about is which has entered clinical trial, and we'll probably be getting data on this year, is rather than picking between BCMA and GPRC, why not do them both along with the T cell binding? So that's called a trispecific, which has entered a clinical trial. There's also a couple of compounds targeting NK cells, not just T cells, and those are shown at the bottom. We have not yet heard clinical data from these yet. So now what about moving these products to earlier and in combination? So we have Talquetamab, which is the Majestic 1, which was initially approved based on this study with 5 prior lines of therapy in about 160 patients. Many had exhausted drug classes, 80% were what we call triple class refractory, which means IMiDs, PIs, and CD38. And the response rate was decent, right, for such a heavily treated 63%. Now, there's some other combinations where we're combining Talquetamab with Dara and Revlimid or lenalidomide, and now in smaller numbers. You can see these are all very small numbers, but these are kind of tantalizing future directions. So Majestic 2, the response rate was 94% with the triplet combination. Majestic 5 is actually newly diagnosed patients with daratumumab and Revlimid in the 20 and 19 patients. 90% response rate, and look at that MRD negativity, 100%. Same thing, Majestic 4, this is also newly diagnosed, but this is not pre-transplant, it's consolidation post-transplant. And what this does in those 30 patients in each arm, the rate of complete response goes from 1/3 of patients to 90%, and MRD negativity goes from 80% to 100%. And finally, smoldering myeloma, Immunoprism on the very right, again, small numbers, 10 patient, 100% response rate, 100% MRD negative. Right, so this is really exciting. This is the future of myeloma. This is what we've been looking for, 100% response rate, MRD negative. Now, of course, we have to keep in mind, so I think what you're seeing here from this arrow is that as you move to less heavily treated patients, from 5 to 2 to 0 to smoldering, probably the immune system is better, and that's why you're getting a better response rate. But we really have to be mindful. These are new products. Infections are still happening. It would be tragic to lose a patient to a serious infectious complication who has all these other options still remaining. So we need to really balance this efficacy and safety to make sure that we're not getting these serious neutropenia and infections. But really exciting, I think, for the field to try to move these products earlier. We also wanted, I think we talked a little bit in the breakout about sequencing. So what do we know about sequencing? So TEC and ELRA, as currently proved on the heavily treated patients, they were not allowed to have prior BCMA-directed therapy, right? So these were BCMA targeting, and you could not have had prior BCMA, and the responses are 60%, remissions say 1 to 1.5 years. What about if you give prior bispecifics? Now, if you look at Talquetamab, if you got a prior CAR-T in 15 patients, the response rate was okay, but the remission drops to 4 months. If you give a prior ADC, this is the antibody-drug conjugate, like Belantamab, that also seems to be less, 7.3 months, and same story with elranatamab. If you give ELRA after a prior BCMA CAR-T, that remission is only 10 months, and prior antibody-drug conjugate, 3.9 months. So it does appear, again, these are limited by the fact that small numbers and probably everybody was getting everything at full dosing intensity, right? There was not a lot of breaks in time between. But what we see here is that the remission duration of a BCMA bispecific, whether it's TEC or ELRA, does seem to be reduced if you're giving it after another BCMA targeting agent. What about Talquetamab? Because now you can switch the target. So here are the 2 doses of Talquetamab, weekly or every 2 weeks, 70% response rate, remissions lasting 7.5 and 11 months. This is the data I was alluding to, that every 2-week dosing, which is more convenient, actually is a better efficacy, right? 11 months is better than 7.5. So it's nice to have a product that's less frequent and actually gives you better efficacy. But what about prior T-cell redirection? Here, what's interesting is if you give prior CAR-T or bispecific, it makes a difference of what you're getting. The responses are good. Prior CAR-T, 12.3 months, looks just as good. But the prior bispecific is only 4 months. So what this means is that switching the target is not enough. Even if you go from BCMA to GPRC, if you're giving it after a prior BCMA bispecific, we still need to do better. And we think the reason for this is, again, that exhausted T cells, right? So if you're giving one bispecific, the T cells get exhausted, it's going to be compromising the next bispecific as well. And it's not the response, or you can see we were discussing earlier, what's the best endpoint, response, PFS, et cetera. Response is decent, 60%. It's the remission duration that's really dinged. So what can we do? Fortunately, a lot of exciting combination data with TAL. TAL plus DARA, 19-month remission. TAL, DARA, POM, 15 to 20-month remission. TAL plus TEC, this just came out this year in the New England Journal. We don't even know, the median hasn't been reached. It's over 18 months, including in extramedullary disease, which is the real unmet need. So we don't even know how long this remission is with the double combination. And finally, TAL-PLOM in 2 lines of therapy, still doing very well. So what makes TAL unique, we talked about the skin, nails, and oral issues, but those side effects don't overlap with other myeloma drugs, which means that you can combine this more thoughtfully, and these remissions are looking quite good. The only issue I'll mention is many of us are having to do off-label combinations, meaning these things are not yet approved, but we need to try to do better, so we often reach for drugs that we can combine, and because of our crazy insurance system, it's easier to add an oral drug than an injection drug, because somehow the way our insurance systems work, if you try to give 2 injection drugs that are expensive, you get pushback. But if you throw in an oral drug on the side, you can sneak it in. The caveat I would make is the IMiDs you can't start when you're doing cycle 1, right? Because you got to get past all that cytokine release stuff. Cycle 2, you can think about it, but you still have to use a lower dose. So for example, in the clinical trials with POM, we only use 2 milligram. Full dose of POM, many of you might know, it's 4 milligram, then there's 3. We can only do 2. And in spite of lowering the dose and starting at cycle 2, many people end up having to come off the drug because it's a tough combination, but it might be something you can do. The other important thing, and where bispecifics are being explored, is in what we call bridging therapy. So as we kind of talked about CAR-T, you have the actual T-cell collection, which is called the apheresis. Then you actually get on the bridge, and then you go to the actual CAR-T, which is the lymphodepletion. So one big no-no is do not do a bispecific before the T-cell collection, right? Because that's where the remissions are really affected. But there's now emerging data that you can do it after the T cells are collected. And what am I referring to? At ASH, we had 77 patients who got TAL as their bridging therapy, and they did quite well. So this might be a good place to use bispecifics. In somebody whose myeloma is really taking off and they're a good CAR T candidate, but you want to control the myeloma before they go to CAR T. So just lastly, there's a lot of exciting studies going on. These are all the phase 3 studies, and rather than reading line by line, I'll summarize what the themes are. So the phase 3 studies are basically comparing bispecific plus or minus DARA to a control arm, bispecific plus DARA plus or minus an IMiD. There's also umbrella studies where these drugs are being combined with each of the other drugs like DARA, ESA, IMiD, PIs. And there's also some really exciting early combination studies combining these with cell mods. Many of you know these are not the next generation of LEN and POM checkpoint inhibitors. So because we can try to target other immune modifying proteins, maybe these will help rescue those T cells that are exhausted. And so my conclusions, these are the new monoclonal antibodies, and we have more and more approvals in many diseases. They're off the shelf, and I believe there's no absolute contraindication to these because you can always hold a drug in the event of side effect. Both targets have showed excellent efficacy in heavily treated patients. We need that initial dose to get the response, but then later we can reduce the dose or frequency. Cytokine release ICANS is manageable, and the other side effects are based on the target with the BCMA, the infections, GPRC, these oral skin nail, and they require what we call supportive care. And to date, one of the questions is how many of these do we need? And I think it's good for the market, right, to have multiple bispecifics because it drives down the cost. But I don't think there's a big difference in how well they work or the safety. I think where you're going to see differences is really the number of step-up doses, whether it can be done all outpatient, how frequently they get dosed, how the drugs are being given. That's where we may be seeing a difference. And of course, cost, right? More products in the same class means cost hopefully will come down. And the ability to move these earlier and in combination will likely be guided by the safety. So, and finally, we're really excited about these new clinical trial structures, the trispecifics and sequencing. Just wanted to acknowledge my entire myeloma team at UCSF, and thank you all for your attention.